Okay, good. So we are going to do a case-based discussion, and I've got a quiz embedded in the slides. Just have your phones ready. There is a QR code. It's easy sign up. So just to set the scene, this is you on a weekend on call. You're holding the ward cover bleep, and you've been asked to see a 40-year-old gentleman was admitted via medical ESTEC for severe hypertension. And the nurse asks you to see a patient who's having a panic attack, and those are his vital signs. A very high blood pressure of 190 over 100, tachycardic at 130. He's maintaining his heart on room air, however, with a respiratory rate of 30. And before you run to the ward, you give an instruction to the nurse to perform an ECG. And when you get to the ward, you find a young man sitting on the edge of the bed who's breathing into a paper bag. He's covered in sweat, looks anxious. However, he tells you that you can feel his symptoms are settling. As a well-trained doctor, you do an A to E, which turns out to be normal, except a slightly raised respiratory rate of 20. The nurse repeats blood pressure check, and it's 145 over 85. Temperature is only slightly raised at 37.6. The nurse hands you an ECG, which she has done earlier. And this is the ECG. I'll give you a few seconds to look at the ECG. Then on the next slide, you can tell me what you think about the ECG. What are the main findings? Right, if you can have your phones ready, let's hope this works. I'll give you another 20 seconds just to connect. I'll wait for 5 more names. 2 more. All right, we'll crack on. 1 more. Okay, that's the first quiz. What does the ECG show? Give you 20 seconds to answer.
Can we see the ECG again, please?
Okay, I'll go back. I'll give you another 5 seconds to look at the ECG. Now you've got the answers. Right, we'll crack on. Okay, so the majority says the ECG shows sinus tachycardia and LVH. I think those are the correct answers. I'll go back to the ECG quickly. So if you look at the rhythm sleep, so it's P wave before every QRS. So that suggests a sinus rhythm. Okay, and the rate, if we look on here, so 3 big boxes is about 100 beats per minute. 2 big boxes, that is the RR interval, is about 150 beats per minute. So this is between 3 and 2. So it's about 130 beats per minute. So that's a sinus tachycardia. The S wave in V2 is very deep. And again in V3 is very deep. The R wave in V5 is tall, as well as the R wave in V6. So that's left ventricular hypertrophy by voltage criteria. So the ECG is showing sinus tachycardia and LVH by voltage criteria. Okay, good. So if you just write what blood test would you perform for this gentleman after that quick assessment that you have done. ABG, good. Yeah, metanephrines. VBG, D-dimer, bond profile. Okay, good. So I agree with a lot of those answers. So at this point, we'll do your usual routine bloods, full blood count, electrolytes, urine dip is very good. Do a VBG, ABG if you're able to. However, it's saturating 100% on room air. So a VBG will work very well. For lactate, his lactate comes back at 1.8. You send off the rest of the routine bloods. So you speak to your registrar who's on call with you. He's busy in A&E. You tell him the story and you tell him that the patient is settling and seems stable. The patient tells you that he actually feels that he's now back to normal. So the registrar says, I'm busy. Can you take a detailed history? However, I'm available on the phone to give you support if you need it. Then you get a detailed history. It tells you that for the last 6 months, he's been getting intermittent episodes of severe headache, palpitations, profuse sweating, and a sense of impending doom. This is unpredictable, lasts anything between 15 minutes to an hour, and is also associated with anxiety, occasional tremors, which has significantly impacted his quality of life and daily activities. He denies any chest pain, syncope, or neurological symptoms. And before coming into hospital, he wasn't on any medication, and he's got no past medical history. So at this point, what do you think are the possible diagnoses? If you just write what you're thinking. So pheochromocytoma, anxiety. Yeah, pheochromocytoma in bold, carcinoid, cons, thyroid, overactivity or underactivity. So something thyroid, hyperactive thyroid. Good. Overdose, anxiety, so I agree. All those symptoms sort of fit with the differentials that you've put. Pheochromocytoma comes at the top. Anxiety, carcinoid, illicit drug use, stimulants like LSD would present more or less the same. So move on. So your registrar, you speak again to your registrar, who then says the likely diagnosis is associated with familial syndromes. Can you take a detailed family history? So what are some of the familial syndromes associated with the likely diagnosis? So I've got lots of people voting for multiple endocrine neoplasia. Neurofibromatosis type 1, anyone? Von Hippel-Lindau syndrome, anyone? Osler-Weber-Rendu syndrome, anyone? Okay, I'm going to close the poll. All right, so we'll get back to this in the discussion. But most people seem to think that the likely diagnosis is associated with MEN type 2. So routine bloods come back normal except a mild hypokalemia. And you've done 24-hour urinary metanephrines, which come back significantly elevated. Non-metadrenaline is about 5 times the upper limit, and metadrenaline is also 5 times the upper limit. You do an abdominal ultrasound scan, which shows a complex right adrenal cyst. So what do we think the diagnosis is at this point? Does this give the diagnosis?
Excuse me, right adrenal or right renal?
Sorry, it's right renal cyst. So it's an ultrasound scan, it's not localizing it properly. The sonographer says it's a right renal cyst. Would you want to do anything else? You've got metanephrines.
CT?
Okay, so I think this gives a diagnosis of pheochromocytoma. And obviously, because you're wondering whether this is a right renal cyst or a right adrenal cyst, you arrange for a better cross-sectional scan, which is a CT abdomen. And the CT shows a right suprarenal mass with cystic and solid components. And we think this is an adrenal tumor. So together with the biochemistry and the imaging, we make a diagnosis of pheochromocytoma. Okay, so what are the treatment options at this point? We've got 40-year-old gentleman who's presented with severe hypertension, episodic palpitations, and sweating, and you've made a diagnosis of pheochromocytoma. Right, so a lot of people voted for surgical resection, that's correct. Alpha blockers, that's correct. Beta blockers, that's correct. And maintaining adequate hydration, that's correct. So all of the above is the correct answer. We'll talk a little bit about this in the discussion. Ignore the leaderboard. So the patient is started on phenoxybenzamine, which is an alpha blocker to stabilize his blood pressure and prevent intraoperative hypertensive crisis. A beta blocker was later added to control tachycardia. And once he was hemodynamically stable, he was scheduled for laparoscopy, right adrenalectomy. This was done, and histology was consistent with a pheochromocytoma. He recovered well, and we repeated serum metanephrines 7 weeks post-surgery, which were within normal limits. We repeated a CT scan at 3 months, which showed no signs of disease recurrence or distant metastasis. So the patient is recovering well with no signs of metastasis. So we'll talk a little bit about pheochromocytoma and paragangliomas. So these are rare neuroendocrine tumors. They are catecholamine secreting, and they develop from the chromaffin cells. The majority arise from the adrenal medulla, and we call these pheochromocytomas. However, about a fifth of them arise from the sympathetic ganglia, and we call them paragangliomas. So 98% arise within the abdomen. So no one will fault you if you do an abdominal ultrasound or abdominal cross-sectional imaging to look for a pheochromocytoma. They are very rare. The incidence is about 2 to 8 per million, with a prevalence of 1 in 2,500 to 1 in 6,550. However, the incidence is rising. Does anyone know why the incidence seems to be rising? I don't think the disease itself has become more common, but I think we're diagnosing it more. Does anyone know why we're diagnosing it more?
Maybe people with the syndrome are surviving more with men.
That's a good guess. The main reason why we're seeing it more is we're picking up a lot of incidental pheochromocytomas because we're using lots and lots of imaging. So we're picking up chromocytomas where we would have imaged someone's abdomen to look, to investigate deranged LFTs. Then we find they've got a right suprarenal mass, which was otherwise asymptomatic. So this peaks between the age of 40 and 50, 10% in children, and there's no difference between men and women. The majority are sporadic. However, about 30 to 40% have a genetic mutation, and these are associated familial syndromes. Neurofibromatosis type 1, Van Hippel-Lindau syndrome, multiple endocrine neoplasia, both type 2, both 2A and 2B, and something called familial pheochromocytoma and paragangliomas. So you need to get a detailed history. So the presentation is secondary to catecholamine excess. So if you think of your adrenaline flight fear response, this is just exaggerated. So the patient gets spells of 5 Ps for those who like mnemonics. Pressure, which is hypertension, pain, which is headache, episodic perspiration or diaphoresis, palpitations, and pallor. So the frequency varies from monthly to several times a day, and duration can be anything from seconds to hours. The spells become more frequent and more severe as the tumor grows. And associated features can be tremor, nausea, anxiety, and sense of impending doom, and constipation. Clinical signs, paroxysmal hypertension is the commonest in 50% of the patients. However, something to remember is that the prevalence of pheochromocytoma in hypertensive patients is less than 1%. I know most of us, if asked about the causes of secondary hypertension, would think about pheochromocytoma at the top of the differential list, but this is very rare. However, I will not stop looking for it. I, for one, would do 24-hour urinary metanephrines in almost everyone with resistant hypertension. Weight loss is one of the associated signs, and neurofibromas. These are cutaneous tumors which can easily be picked up on physical examination. Patient can present with tachyarrhythmias. They can present with pulmonary edema. And cardiovascular symptoms and arrhythmia contribute to 71% of the mortality associated with these tumors. This is how you make a diagnosis. I think for you, I would say speak to your lab first and find out if they can do plasma metanephrines, because not all centers can do this. If they can do this, then this is something that you can easily do because it's quick. It's just a single blood test. If not, almost all labs can do 24-hour urinary collection for catecholamines. If you do it on an outpatient basis, then you'd have to instruct your patient to start collection at the same time. Start at 11 a.m. today and finish 11 a.m. tomorrow. Nothing more, nothing less. And pass all the urine into the container. Then after you've made a diagnosis, a biochemical diagnosis, then you move on to imaging tests, which can be an abdominal CT, which is fairly accurate, an MRI, which is preferred in children, pregnant and lactating women, and scintigraphy can be used in those who are biochemistry positive, but you don't pick up a tumor on CT or MRI. You can do additional tests, especially if you're thinking about familial syndromes. So serum, parathyroid hormone and calcium, when you're thinking about MEN type 2. You can also arrange for an ophthalmology exam for retinal hemangiomas or Van Hippel-Lindau disease. And when there's more than one family members affected, you can arrange for a genetic test. So management follows an MDT approach. Surgical resection is the treatment of choice, and often it cures hypertension. But however, the patient has to have careful preoperative treatment with alpha blockers initially and beta blockers later on to control blood pressure and prevent hypertensive crisis. So we start with alpha blockade, phenoxybenzamide 7 to 10 days pre-op. Does anyone know the reason why we start with alpha blockade before we initiate beta blockers? I've got it on the screen, I've just realized. So the reason is to avoid unopposed alpha stimulation. So this will cause a hypertensive crisis. And make sure that your patients are adequately hydrated. So volume expansion with normal saline in the pre-operative period and encourage salt intake. Then when the patient is well established on alpha blockers, you initiate a beta blocker. And surgical resection can be open or laparoscopy. And it has to be done by experienced surgeons. Prognosis. So for non-malignant tumors, the prognosis is very good. 5-year survival rate, 95%. For malignant tumors, the prognosis is very bad, less than 50%. And the reason is that it's difficult to take out all the tumors once they start to metastasize. However, malignancy is very rare, about 1 in 10. Post-operative follow-up and surveillance are essential. European guidelines recommend plasma metanephrines about 2 to 6 weeks after surgery. If the biochemistry is still high or the tumor was deemed non-functional, then you do imaging test at 3 and 6 months after surgery to make sure that there is no mets and that the tumor has been fully resected. So in summary, rapid recognition of pheochromocytoma is very crucial because the cardiovascular complications can be lethal in some cases. And diagnostic workup, plasma, metanephrines, 24-hour urinary collection, and imaging. Preoperative management is key. Alpha blockade before beta blockers, and ensuring that your patients are well hydrated. Multidisciplinary approach for best outcomes. So I'm just working a little bit backwards here. So those are our objectives. I'm sure we've met all of them. And I'll open the floor